Hello, I'm Matthew Balti with the Acoustic Neuroma Association. I'd like to welcome everyone to today's ANAwareness Week presentation on gamma knife radiosurgery for acoustic neuroma, indications, risks, and recurrence with Dr. Rupa Jatani of Valley Health System. We'll begin shortly, but first a couple of quick items. Captions are available for this presentation at the bottom of your screen. This presentation is part of our ANAwareness Week, so make sure you stay connected to the ANA through our social media pages on Facebook, Instagram, Twitter, and LinkedIn. Also, make time to visit our website, anausa.org, for more up-to-date information on ANAwareness Week, view resources and videos, study clinical trials, connect with others, and more. A special thanks to all of our medical partners who helped make this week happen. Now, Dr. Jatani, if you'd like to turn on your camera and introduce yourself, we can get started.
Great, thank you. Hi, everyone. It's such a pleasure to be here. I'm, so grateful for the Acoustic Neuroma Association for sponsoring this. It's so important that we talk about acoustic neuroma and really understand what we're talking about and the potential treatment options. So I'm going to go ahead and share my screen here. All right, are you seeing that okay?
Yes.
Okay. All right, so today we're going to be talking a little bit about gamma knife radiosurgery. So you're going to be hearing a lot about acoustic neuromas and various treatment options, and we're really going to focus on gamma knife, what the indications are, what the potential risks are, and what you do if there is a case where you do the gamma knife and then the tumor comes back afterwards. So the objectives here are going to be to review the common presenting symptoms. This is really where we find out that we have an acoustic neuroma, and it's really important to differentiate the things that can clearly be attributed to the tumor versus things that are sort of just incidental, meaning you have some symptoms and then it just so happens that you find out that you have an acoustic neuroma on the MRI. We will talk about treatment options. We'll review the impact of timing and intervention specifically with relation to gamma knife radiosurgery on function and outcomes, and discuss how we really tailor our treatment strategies to the individual patient, particularly in the case of recurrence. So first, let's define an acoustic neuroma for anyone who needs a little bit of a refresher. So first, the big question that comes up is this an acoustic neuroma or a vestibular schwannoma? Now, these are really just two names for the same thing. Technically, schwannomas are tumors that arise from the nerves of the brain, and neuromas we really talk about as tumors that arise from the nerves elsewhere in the body. So technically, the term schwannoma is really the accurate term, but we use them interchangeably. Even us as physicians say acoustic neuroma because it tends to be something that people recognize a little bit more easily. So they mean the same thing. They're the exact same tumor. The name comes from the root word. Acoustic means hearing, vestibular means balance. So, these are tumors that truly arise from that vestibular, the balance nerve, but they run right along with that acoustic nerve. So these are both accurate terms in terms of describing the location that the tumors are occurring in. So these are benign and slow-growing tumors. Probably one of the biggest questions I get is, how do you know that it's benign? Well, tumors in this location have a really characteristic appearance. We have studied these for decades. We know the appearance of it. There are rare circumstances where it has an appearance that is not typical of a vestibular schwannoma, and your doctors will know that. But in almost all cases, these can really be diagnosed essentially by MRI. So it's not one of those cases where you need to do a biopsy to know what it is. We know what these are based on the location and the appearance on MRI. They typically arise from that vestibular nerve. It's a branch of the eighth cranial nerve, which is actually the nerve that controls hearing. And that's why the symptoms can be correlated with either the vestibular function, the balance function, or the hearing function. And the tumors can arise anywhere along the entire path of that nerve. So they can occur near the brain, right where the nerve comes out, or they can occur further out near the hearing apparatus, the cochlea, which is where the nerve plugs in. They can occur anywhere in the inner ear, which we call an intracanalicular tumor, when it is really just confined to sort of the bone part and not really involving the brain part at all. or they could be both. They could start in the brain area and then they can extend out to that inner ear area. So what are the symptoms? Well, it's very common for patients to present with hearing loss on one side. Now, a lot of people as they get older develop hearing loss. That is not in any way something to be alarmed about. But when your hearing loss is asymmetric, when you have hearing loss that is clearly more on one side than the other, that's usually when an ENT doctor or another physician will order a scan to make sure there's not something causing that asymmetry in the hearing. Sometimes people have a ringing in the ear called tinnitus. Sometimes people present with dizziness, vertigo sensation where the room is spinning around you. Could be episodes of that, or headache. I would say headache is a less common symptom of a tumor like this. In most cases, when patients have headache, this is actually an incidental finding, meaning the tumor itself is not really causing the headache. We just happen to look for something and we found it. If you may think that this is actually a problem with their ear. A lot of my patients say that they have fullness in the ear, and so they end up going to an ENT doctor to see if they can see something in the ear, and they will not be able to see anything, but they usually are able to pick up on there being an issue with your symptoms or with the testing of your hearing. We typically make the diagnosis based on a CT or an MRI. An MRI is much higher resolution, but CT scans are usually enough to pick up on certainly substantive tumors. Really tiny tumors can only be seen on MRI. So the symptoms you have really depend on the size and the location. Small tumors are often incidental if they're not deeper in the ear canal. Actually, the deeper you go in the ear canal, even tiny little tumors, 1-2 millimeter tumors, those can actually have really significant effects on hearing and can have a lot of symptoms. When they're inside the ear, they can cause that early hearing loss or ringing. It is really difficult actually to predict who is going to have hearing loss. I have patients that have 3-4 centimeter tumors with really good hearing, and then I have patients with tumors that are only a few millimeters, tiny little tumors that have complete hearing loss. So it's really very patient specific and location specific. It's not easy to predict. So I always counsel patients that any vestibular schwannoma puts you at risk for hearing loss, and that's something that we watch for really carefully. The size itself is not a predictor of whether or not you're going to have hearing loss. So this is an example of what the tumor looks like when it's completely inside the ear. So the nerve is coming out of the brainstem, and you see this bright area here with contrast, and that is what we call an intracanalicular or tumor in the inner ear. Larger tumors are more likely to cause symptoms of imbalance or weakness, and they can cause pressure on the brain, and that's why you see different types of symptoms. And hearing loss may be a later effect of the tumor. That's an example of a large tumor. So what are the treatment options? You've heard this probably from many people, but really we have 3 buckets of treatment options. We have observation, we have surgery, and we have radiosurgery. We'll go quickly through the indications for observation and surgery and then really focus on radiosurgery and gamma knife. So we observe small asymptomatic tumors. We observe tumors in patients that are older without symptoms, or in patients that are just not candidates for surgery or radiosurgery for a variety of reasons. And we're going to talk a little bit more about even those small asymptomatic tumors, how we are really careful in those patients about selectively treating some of those with radiosurgery in order to preserve function. So we really focus surgery on large tumors that are causing pressure on their brain, particularly in younger, healthier patients, even when they're asymptomatic, when it's really large. In older patients, if there's a large tumor causing pressure-related symptoms, surgery is really the best thing to immediately relieve that pressure. Sometimes these tumors are so big that they're causing a backup of fluid because it essentially pinches the bottom of a plumbing system in the brain. Small tumors, we typically reserve surgery for small tumors for select patients that are younger. Maybe there's a tumor that is outside of the ear canal and we really want to preserve hearing. And so those are sort of unique cases where we're operating on small tumors. But for the most part, small tumors are not really ideal candidates for surgery. Sometimes when the main symptom is ringing, if that is just a debilitating symptom, we may consider surgery because it's more likely to improve that ringing symptom than the radiosurgery. So now let's talk a little bit about radiosurgery. So radiosurgery is highly focused radiation. We use several hundred beams of radiation that concentrate on a target. It is so accurate that we're literally able to target a 1 millimeter spot. The accuracy is sub-millimeter. Gamma knife radiosurgery is a unique form of radiosurgery that was designed specifically for the brain, and it has unique characteristics that allow us to treat tumors with a very good dose while having a really, really good protection of the structures around it. That's what we call a steep fall off. So that allows us to target the tumor while preserving the surrounding brain and important tissues. One of the important tissues in this area is called the cochlea. That's really the hearing apparatus. And so we can tailor this treatment so precisely that we can say exactly what dose everything gets in the area. And that's what makes it the treatment of choice for these types of tumors. Each individual beam, because they're so small, have no real effect. So when they concentrate, that's when the effect is additive. The treatment effect, interestingly, is not dependent on whether or not tumors are sensitive to radiation. It really actually has this sort of immune effect where it's launching the immune system to recognize this tumor and help your own body take care of it. So it's a really unique treatment, and we can tailor these treatments to the goals. So it's so critical that the neurosurgeon, radiation oncologist that you're working with are looking at the hearing, are looking at the likelihood of being able to preserve that hearing, looking at how close the tumor is to the hearing apparatus. All of these things dictate what dose we should give and where we should tailor that dose in order to achieve the goals. So what is gamma knife radiosurgery like? Well, in our set, we can actually do radiosurgery with either a mask, which is something that's put over the face, or with a frame. We tend to prefer the frame, especially for smaller tumors, because we achieve a lot of accuracy that way, and we take out the issue of movement that can sometimes happen, makes it an easier and more comfortable treatment for patients. So we place this thing called a head frame on that is secured in 4 locations, and then we send you to an MRI so that the frame is essentially like a GPS system for the brain. And so we're able to really precisely target the tumor with very, very high precision. And then you go into a machine that kind of looks like a CAT scanner, and you are able to stay relatively immobilized because the frame is holding you in place. And the treatments can, vary in length, but typically they run between 30 and 60 minutes. After radiosurgery, typically you come out of that treatment, that 30, 60-minute treatment, and you're really feeling pretty well. So a lot of patients ask, is it painful? You do not feel the radiation as you're getting it. It has no real effect on you, and you don't feel any different immediately after treatment. After treatment, we usually have given you some type of medication to sort of help make the experience a little bit smoother, and you might not be able to drive immediately afterwards, but usually within about 24 hours, you're completely back to your normal self and can resume all of your normal activities. It's really important that people know that you don't have to come off of any of your blood thinners or anything like that for a treatment like this. This is a essentially non-invasive treatment. We do not require medical clearance. It can be done independent of your other medical considerations. We typically discharge patients about an hour after completion of the treatment. So, if you were to come in the morning, you're pretty much going home, by late morning or, by noon, certainly. You can return to your normal activities afterwards with no real limitations. And then we typically do a follow-up MRI. So what are the benefits of gamma knife radiosurgery? It is a non-invasive treatment. That is really, really critical. Like I said, this means that we can treat anybody. It doesn't matter what your medical conditions are. It doesn't matter what your age is. This is a very safe and effective treatment for a vast majority of people with tumors that qualify for it. There's little to no recovery period. We can tailor this to achieve hearing preservation. And I'm going to be talking about this a lot because I think it's a really important element of our treatments. We have little or no risk to the facial nerve. So the facial nerve is the nerve that controls movement to the face. When we are doing surgery for these tumors, that is the nerve that is most at risk. It is very, very critical to preserve the function of that nerve in surgery. And even in the most experienced hands, that risk still exists. That risk is little to none with radiosurgery. In the rare cases where you do have some facial nerve dysfunction or weakness after treatment, it is almost always temporary. That happens really because that nerve runs right alongside that hearing and balance nerve, but it is not in and of itself directly affected by the treatment. So the effect usually will go away with just some steroid treatment. So the fact that we can preserve facial nerve function is really critical in the use of radiosurgery. We have excellent tumor control rate. So what does tumor control rate mean? That means what are the rates of not having the tumor grow? So what percentage of tumors do we treat where they don't grow afterwards? And those rates are extremely high. They're upwards of 90%. And we look at that over a 10-year period. So it's really an incredibly effective treatment. So what are the risks? It sounds great. Why doesn't everyone get it? Well, tumors don't always shrink in size. I think that a lot of patients have this expectation that you're going to treat it and it just disappears, but it doesn't have to disappear. So the goal here is to stabilize the tumor and to prevent growth. If it shrinks, great. But if we're trying to do a treatment to shrink a tumor, then we really should be considering surgery. So that's why when we have more of those mass effect symptoms where something's putting pressure on the brain, that's the situation where we want to do surgery, not radiosurgery, because it is not consistent whether or not these tumors will shrink. And if they do, it takes time. It can take years for that to happen. You can have progressive hearing loss depending on the dose that is given and the location of the tumor relative to that hearing apparatus or the cochlea. I like to think of the cochlea as sort of like the microchip of the hearing. So, the nerve plugs into that. It's very, very highly concentrated. And when we give the radiation treatment to the tumor, the further that tumor extends into that inner ear area towards the cochlea, the more dose the cochlea will get. So we always are really careful to know, is there good hearing? Is that hearing what we call functional, meaning it is enough that it helps you function or be able to discriminate between sounds? And is it possible to both treat the tumor and preserve hearing function? If the patient has really good hearing, then sometimes, and the tumor goes really close to that hearing apparatus, sometimes we might compromise a little bit on the coverage of the tumor. So we might say, instead of treating 100% of the tumor, I'm going to treat 98%, because that last 2% is just getting too much dose to the cochlea. And that way we can really tailor our treatments in a very, very effective way. Tumors can grow back. Now, that's true with any treatment. Tumors are always susceptible to growing back in some cases. Again, that rate is pretty low, but it exists, and that's why we monitor patients after treatment. There is a risk of something we call radiation necrosis. So radiation necrosis is essentially, think of it as a really, really exuberant immune response. So your body is kind of reacting so much to the radiation that the tumor actually dies really quickly, and that sort of death of the tumor triggers this really strong immune inflammation response, and that can cause a lot of symptoms. So even in sort of the early stages, which is what we call treatment effect, the tumor can actually swell a little bit and look bigger, and that usually precedes a period of it getting smaller. Why is that? It's because that means that there's some kind of immune response going on that usually will trigger your immune system to start attacking the tumor, and then it'll shrink. So it gets bigger and then it gets smaller, and that's very common. Most of the time it can get bigger, and if it's just a little bit, patients don't have significant symptoms from that, or if they do, they're easily treatable with steroids. In very rare cases, when the tumor really gets too big and too inflamed, then we have to consider other treatment options like surgery. Now, the rate of that occurring, the rate of that radiation necrosis occurring, is really proportional in many ways to the size of the tumor. So the bigger the tumor, the more likely that is. That's why we typically have kind of size cutoffs for what we're willing to treat with radiosurgery. Once you get past a certain size, we don't usually want to do radiosurgery. Or let's say you've got a big tumor and you're not a great candidate for surgery, then we might do something we call fractionate. So while most of the gamma knife treatments we do for acoustic neuromas are a single treatment, in cases where the tumor is really large and you're not a candidate for surgery, we might do what we call fractionate. So we divide up that same dose into 5 treatments, and that makes it safer and reduces the risk of that radiation necrosis. So these are all the things that we do to take into consideration the potential risks and how to reduce them. So what is life like after treatment for a acoustic neuroma? So the follow-up MRI is typically done at 3 months and then 6 months and then every year to 2 years. And this really depends on your symptoms. Now, a lot of times in the first year, we may not actually even do that MRI if you're not having symptoms, because we are very used to seeing that inflammatory response where it gets a little bit bigger. And the truth is, within a year period, if you're not having symptoms, we're very unlikely to do anything about that, right? So if it gets a little bit bigger, it's not as though we're concerned. We know that happens. So we may not actually even do a scan until that first year period. We go to yearly follow-up, and then we go to every 2 years eventually once you sort of pass the first 3 to 5 years. And a lot of that's dependent on sort of your age and the size of the tumor. Large tumors that have been really stable over periods of time, we can even have longer follow-ups, 3 to 5 years. And then we do hearing testing yearly as long as you still have functional hearing. And that's really what helps us track the effects of the treatment and the effects of the tumor itself on your hearing function. So now we're going to talk a little bit about how we time intervention. So when do we do the radiosurgery? So before, we used to wait until there were very clear symptoms. We used to wait until there was hearing loss. We used to wait until the tumors were big enough or the tumor's clearly growing. And I'd say that that really was the philosophy that was employed when we were having higher complication rates or we didn't have as precise treatments as we do now with the gamma knife radiosurgery. The treatment intervention times are pretty true for surgical treatments, but they're not really true for gamma knife. So now we're pushing the limits of what we can do with gamma knife and starting to treat these tumors much earlier because we're seeing much better outcomes. And that risk-benefit ratio has shifted. Everything in medicine is about what are the risks relative to the benefits. And as those benefits increase and as the risks decrease, we're really starting to see a higher percentage of patients that are treated at a smaller size tumor and even asymptomatic cases. So know that vestibular symptoms and the ringing may get worse in the first year after treatment, and that is due to an inflammatory response, which we talked about. That typically responds to anti-inflammatory medications. And I always say when we're talking about timing and intervention, I really like to talk about your age, the tolerance to these potential complications, because let's say you're an older patient and balance is really critical for you. We may not use the same paradigms that we use for a younger patient to treat earlier and more aggressively, because the risk of causing worsening vertigo or imbalance, it just may not be worth it in an older patient who is prone to falls anyways. So I take into consideration all of these potential risks when I'm considering the timing of that intervention. Now, these risks are higher and more common if you have them beforehand. So if you're having a lot of sort of imbalanced symptoms, I always say, think about gamma knife as potentially causing a flare in those symptoms. So symptoms may get better before they get worse. In the long term, they're very likely to overall get better, but there's a short-term period, about 6 months to a year, where it may get worse. And a lot of that really has to do with your specific anatomy. So I take into consideration all of this when considering timing of intervention. So now let's talk about the hearing preservation. So why is it that we're starting to treat tumors smaller and more asymptomatic? Well, it's because the data has sort of shown that the rates of hearing preservation after radiosurgery are actually better when we treat earlier and when hearing is better. So we look at the preoperative or pre-treatment quality of the hearing, the total dose to the cochlea, which we've talked about a few times, and the total size of the dose that we're giving, the size of the tumor, and how much that tumor extends into that inner ear space. So what we've found is that younger patients, those defined as less than 58 years of age, with a better hearing going into it, with more space between the tumor and the cochlea, who we can keep the cochlea dose under a certain threshold, they have the best outcomes. And those were compared to patients that were observed. So if we took 2 patients and said, should we treat or should we observe, the patients that we were treating earlier actually were having better outcomes in hearing. And that was looking at both 12-month and 5-year outcomes. And so if you look at 5 years, for example, the outcomes were 81% hearing preservation compared to 32% in the treatment group. The treatment group was 81% compared to observation group of 32%. So what does that mean? Well, that means that if our primary goal is hearing preservation and you're a good candidate, you're young and the tumor has good distance from the cochlea and the tumor size is favorable, then it may be that we say, even if it's not causing symptoms, even if it's not causing hearing loss, the data shows us that if we treat now, you're more likely over a 5-year period to have your hearing preserved if we do the treatment. So that's the type of thing that we're counseling patients on now. So the newer studies are now really recommending early treatment over observation to optimize the chances of preserving hearing long term. And that is really especially true for those intracanalicular or in the ear tumors. And so that's sort of the paradigm that we're following. We use these dose constraints, meaning we set the limits for the cochlea or that hearing apparatus really, really strictly. And we're able to tailor these treatments so beautifully. We're able to pull the dose away from that cochlea and really focus on the tumor itself in really sophisticated ways now. So what are the benefits of early radiosurgery for small and asymptomatic tumors? Well, the benefits are that we can offer really high rates of hearing preservation. We can prevent symptoms of tinnitus and vertigo from developing. So let's say you have complete hearing loss and we really can't preserve that. It's still helpful to treat these tumors to prevent other symptoms from developing in the long term. The smaller the target, the lower the dose of radiation to the surrounding structures, and the more effective it is. So it's always better in general to treat tumors when they're smaller. Now, what are the risks? It can contribute to hearing decline if the tumor is really close to the cochlea. So that's always something I counsel patients about. We can get that temporary new symptoms or worsening of symptoms like we talked about with that flare. And if your hearing is below a certain threshold, I always say we do not expect hearing preservation and we will focus on tumor control, meaning we will treat the tumor, but we do not expect to be able to preserve the hearing. So expectation management is really critical for these cases. So what are the risks of waiting? Well, sometimes in older patients, like I talked about, if we're really worried about the potential side effects, we may wait. Once the symptoms start, they can be hard to treat. So most respond really well to steroids and to minor interventions. But, all of our treatments are actually generally better at preventing symptoms than they are at treating them. So let's say you have really bad tinnitus. The treatment is not necessarily going to make that better. But if you were to only have really mild tinnitus, then in the long term, actually treating early might help to prevent progression of that in the longer term. Now, the risk of injury to the surrounding structures increases with the size of the tumor. So again, we always prefer to treat when they're smaller. And then certain types of tumors with certain characteristics like cysts, those can blow up really quickly. And so we like to treat those earlier. Hearing can decline really rapidly. And I always tell patients, we see a slow decline in hearing, but in some cases, patients suddenly lose hearing. And once you lose hearing, I really can't do a whole lot to bring it back. So patients should always be really vigilant about their hearing and know that one of the risks of waiting is that we might lose that window of opportunity to preserve hearing. The sudden hearing loss is really, really unpredictable. I actually see it more with smaller tumors than I do with larger tumors. So gamma knife radiosurgery for recurrence, this is the last major thing we're going to talk about. So while there are very high tumor control rates, there's a small percentage of patients that will still have their tumor grow despite treatment. Retreatment is actually an option for these cases once you're outside of the window where we see that treatment effect or that radiation necrosis. That's typically a minimum of 3 to 4 years after your initial treatment, and it depends on what your tumor looks like and what dose you got. The MRI findings and the pattern of growth over a period of observation help to guide us. Retreatment success rates are nearly identical to the first treatment. So that's, really important thing to know is that just because you didn't respond the first time does not mean you will not respond the second time. We typically look at treatment characteristics and try to tailor it accordingly. So how to decide? Determine your goals and determine your quality of life measures. Evaluate your tolerance for risk. Discuss the risk-benefit ratio specifically for your tumor with your neurosurgeon and your radiation oncologist. This is very unique to each patient and tumor. It's a very complicated algorithm. Make a plan and stick to it. So I always like to get involved early. I say, hey, at the first sign of hearing decline, at the first sign that the tumor is growing, we're going to treat it. So we have a plan in place and we're on the same page. And that's what helps us all be prepared for the next steps. So this is our team of neurosurgeons. I'm fortunate to work with Dr. D'Ambrosio and Dr. Cobb and our amazing physicists. We've got amazing nurses that make the experience absolutely phenomenal at Valley, and our radiation oncology team. So that's it. Let me know if you have any questions. And here is our number in case you want to get in touch with me or make an appointment. I'm always open to doing second opinions if that's helpful for you. We offer a lot of telehealth services for people who are out of state. So the most important thing is that you feel empowered and you have all the information you need for yourself and your loved ones to make an informed decision.
Great. Thank you, Dr. Jatani. If you want to go ahead and stop sharing your screen, we do have a handful of questions to get into. We know that a lot of patients will hear things like they'll hear gamma knife, but they might also hear about CyberKnife or some other types of forms of radiation. What are the differences in those offerings and that terminology, and what factors kind of go into those different ones?
Yeah, so that's a really important question. Now, I can speak as someone at a center where we have both types of technology, right? And so, it's very easy if you only have one type of technology to say that's a good one or that's the best one. We have both, and we really almost exclusively use gamma knife for these tumors. And so why is that? It's because the technology, it was really designed for this function. It was designed for the brain. It has what we call a very steep dose fall off, which means that when we treat the tumor, the area around it, the dose drops dramatically, really dramatically, compared to the other forms of radiosurgery. So that's not always necessary for all tumors. There are a lot of tumors where you get a little bit of dose to the surrounding area and that's just fine. But when I'm talking about trying to protect a structure that's half a millimeter away from the tumor, that steep dose fall off, being able to really tailor my dose in order to be conformal, meaning be really, really tightly treating the tumor while having a minimal dose around it, that becomes critical to being able to achieve my goals. And so that's why I exclusively use gamma knife as my form of radiosurgery for these tumors, even though we have other technologies that do that. So I do think that's really important. It's important to have some transparency in the centers that you're going to. If they're choosing something that's not gamma knife, make sure it's not because they don't have the gamma knife, because a lot of places don't. So I think that's a really important question. It's really important to go to centers of excellence that really do a lot of these. A lot of the algorithms are based on just having a high volume and having a good system for knowing what to treat, how to treat, what dose to treat.
Great. Thank you for clarifying those. You mentioned how after treatment there might be some side effects with the vestibular systems. Are there any side effects that might affect some cognitive ability after radiation?
Not typically. It's a good question. There are some cases, certain types of tumors, particularly the cystic tumors, you can actually get a certain amount of inflammation that we think maybe gets into the spinal fluid. So for some patients, you can actually develop a backup of spinal fluid. That particularly happens with sort of larger tumors, more cystic tumors, but we can see that. So we do watch for that, what we call hydrocephalus, which is where you get that fluid backup. And we ask patients symptoms that are related to that. That can be memory issues, that can be sort of feeling wobbly, that can have some urinary issues. So we screen those patients. We kind of have a good sense of who's at risk for that. I'd say a vast majority of patients are not at risk for that, but there's a very small minority that are. Otherwise, there's no real cognitive function or higher level function in this part of the brain to be worried about at all.
Would fatigue be something that people might experience after radiation treatment?
That's a good question. It's not that type of radiation, so it typically doesn't cause fatigue. So it's not, sort of exhausting in that way. However, I would say, I think that patients that experience a lot of tinnitus or experience a lot of vertigo, that can be fatiguing in its own way. And it can kind of give you a brain fog just because of that, even though it's not actually affecting your energy and it's not affecting your cognitive function.
Absolutely. You mentioned that there will be a cutoff for tumor size where someone might need to go ahead and have surgery instead of radiation or radiosurgery. Is that a pretty standard size, or can that differ depending on the patient?
Yeah, it certainly differs. Our threshold is certainly lower for younger patients. So, for a younger patient, something over, let's say about 2 centimeters, we're really, really closely considering surgery. For an older patient, we might push that limit. We might say, well, the risks of surgery are pretty high in an older patient. So maybe we're treating at 2.5, maybe even up to 3 centimeters. We're considering, radiosurgical treatment for it. So we alter that threshold depending on the risks of the alternative treatments. So it's somewhat in flux dependent on that. So it's always patient specific.
Great. We had a patient write in. They had gamma knife treatment for a 1.2 centimeter acoustic neuroma about a year ago and had a follow-up MRI that shows that the tumor is now at 1.4 centimeters. How would they know if that small increase is just swelling or if they're actually having regrowth?
That's a great question. I would say almost always with that amount of growth in that period of time, that is not something I would be particularly concerned about. Now, you'd have to look at the specific MRI, and there's certain characteristics that are more suggestive of it being a treatment effect. So I would have to look at that personally to say that. I'll say in general, that amount of growth in that period of time is more consistent with a treatment effect, and I would probably observe it unless there were other characteristics on the MRI that made me concerned.
Great. And one last question we have here. What is the longest term study that's been done on radiation effectiveness and incidence of regrowth?
That's great. That's a great question. Most of the studies we're looking at are somewhere in the 10 to 20 year range, I'd say. While we do have data that goes back further than 20 years, I would say the technology has evolved so much that we're really focusing on consistent treatment. So, I think we've been consistently treating things a certain way for at least the past decade. So I think our 10-year data is really, really good. We don't really have like a 40-year effectiveness, which is part of the reason why with younger patients, I say, if I have to give you 40, 50 years of, life without this tumor, I can't necessarily guarantee that I can give that to you without recurrence with the gamma knife because we just don't know. But overall, our data is really, really looking very, very good. And I think it's important to keep in mind, too, that, in a younger patient, let's say we treat the tumor and it happens to come back in 20 years, we have options at that point, right? We can retreat, we can always have surgery. So patients always have options.
Fantastic. Well, thank you so much, Dr. Jitani, for sharing your expertise and your time for this Awareness Week webinar. We appreciate what you and everyone at Valley Health do for the ANA and AN patients as a whole.
Oh, my pleasure. Yeah, it's so great to be here. Thank you so much.